Yeah, cannot hear. Yeah, hello. Uh, Hope all can hear. Sudhir, can someone tell if you all can hear?
Yes, I can hear.
All right, so we can start. Yeah, we'll quickly do it because exam is also close by, and we'll quickly do and want to speak a few words about the exam as well, especially the changes and all that, and some small techniques here and there. So we'll quickly go with the question paper. So it's quite easy one, I think, no? So right, we'll go with paper three. Uh, Paper three, actually, this is like this is when the paper was being made, I think there's a error. This is not a MCQ, actually, this is a SBA. So can now obviously what is the most likely diagnosis? Anyway, I mean, try to quickly go through this thing, right? So because we'll try to discuss two papers today. Uh, Anybody? I will not ask for volunteers because maybe it takes time, right? Anybody can answer.
The hookworm infestation.
So hookworm infestation is the correct answer here. Now, if you take a question like this, their testing is these are somebody coming with abdominal pain. So generally for medical questions, there won't be abdominal pain, but there are medical causes of abdominal pain. So actually, most of the causes are listed here. One thing is mesenteric angina. Mesenteric angina, classical history will be postprandial abdominal pain. And of course, there will be risk factors like diabetic, and there will also be other risk factors like smoking, dyslipidemia, those things will be there. Classical will be pain after uh, uh, eating. And then mesenteric angina means there's obstruction in the mesenteric system, but there is no ischemia. So when there's ischemia, you call it as uh, ischemic bowel or mesenteric ischemia. So many terms are being used. So that type of a mesenteric ischemia or a small bowel or a large bowel ischemia, it can cause abdominal pain, acute onset one. It will not be postprandial, it will be a sudden onset, and they will have this jelly-like reddish stool, where kind of stool will be red, and they will have a severe abdominal pain. They will present like a acute abdomen. It's a common cause where the acute abdomen can be missed. Then amoebic colitis over here. Amoebic colitis, I think we have discussed before. Amoebic colitis, generally they don't have a generalized abdominal pain in the periumbilical area. They have a right hypochondrial pain. And if there's an amoebic liver abscess, but if no liver abscess, if the colitis per se, it will be a generalized type of abdominal pain. They will have fever, they will have colitis, and they can have other complication of amoeba. And in the history, they will generally have a history of food consumption from outside and toddy drinking, something like that. And ruptured aortic aneurysm, generally they will have a sudden onset shooting type pain, and their presentation can differ. Generally, it happens in when someone is lifting something heavy, going to the gym, things like that. Leptospirosis, abdominal pain is there, but there is no fever history, so it is out. So other causes of medical causes of abdominal pain, we can say there is renal artery, sorry, polycystic kidney disease, rupture of the cyst, and then there is Hinox-Schönlein purpura can cause abdominal pain. Then recurrent UTIs, nephrotic syndromes, these things also can cause vague abdominal pain and all that. So it's quite easy question. There's anemia and there's eosinophilia. So if you put it together, it is a hookworm infestation. Amoebic colitis generally does not cause a neutrophil infestation, although sorry, eosinophil infestation, although uh, they can have anemia. So most important investigation in pancreatitis. This can be a very controversial question, right? Most important this thing because uh, now since they're asking, we'll take it as a MC. If they're asking a MCQ wise, I mean ultrasound scan is correct. CT scan is correct. X-ray abdomen will change this to acute pancreatitis. If it's not chronic acute pancreatitis. X-ray abdomen generally not indicated in acute pancreatitis. But if it was a chronic pancreatitis, you will see for pancreatic calcifications. And erect X-ray is also not indicated. CRP is not very specific, although CRP is important for prognostication, and CRP will be increased in acute pancreatitis as well. So there is this debate. I think even one day also we discuss about this. I'm not sure in this short classes or in our normal class, but there's a debate what investigation is the preferred one. Now, I think there was a question was in your exam that, or in the last this thing, that whether ultrasound scan is beneficial or the CT scan is beneficial. So, in a practical setting, in a Sri Lankan setting, next investigation will be ultrasound abdomen. But if you see world data, what they suggest is that more than ultrasound, CT is more accurate and effective in clinical diagnosis because they have a high sensitivity and a specificity. But ultrasound scan, the sensitivity and specificity is pretty low actually, although it will be the investigation of choice in a Sri Lankan setting. Right. Any questions after that? Yeah. So next question also is an important concept. What they are asking is whether where they are testing whether you know the definition of nephrotic syndrome or not. So definition of nephrotic syndrome is, I mean, if we go with the questions first. So obviously now best evidence to support acute nephrotic syndrome. So generally nephrotic syndrome, the blood pressure. Now what you need to remember is nephrotic and nephritic, there is no clear demarcation. It is a spectrum. And in this spectrum, pure simple minimal change nephrotic syndrome is in one side. Nephritic syndromes like post-streptococcal glomerulonephritis is in another side. So most of the diseases are, I mean, most practically also what we see is it's the spectrum. It can be anywhere in the spectrum. So generally, if the blood pressure is towards the higher side, it is more likely to be a nephritic syndrome. So answer is wrong. And albumin less than 2.3, this is serum albumin. So if the serum albumin is less than 25 grams per liter, it is a yeah, it's in the criteria of nephrotic syndrome. So albumin is less than 2.3 here, so it is more likely to be nephrotic syndrome. But that doesn't mean that this can't be nephritic syndrome, but this is more likely to be nephrotic syndrome. Gross edema in face and abdomen. So edema is also in the criteria, and what you get is a very gross edema, especially periorbital edema is very significant in nephrotic syndrome, and even you can get ankle swelling. And abdominal distension is not a classical feature unlike of nephrotic syndrome, but abdominal swelling is also seen in patients. So that is true. Gross edema, face and abdomen, it is true. But just remember the abdomen part is the problem. Abdomen is not a classical place for fluid accumulation in nephrotic. And also you have to worry if there is fluid in this, because I mean, if you see the causes of ascites, nephrotic syndrome is there, and nephrotic syndrome patients can develop abdominal pain, especially because they are more prone to infections, because their immunoglobulins are passed with urine as well, and therefore they are more prone to infections, especially urine tract infections and any other infection. Anybody? Peritonitis they can get. And also at the same time, they are more prone to get thrombosis, because they are all these antithrombin factors and all that they are being passed in urine. So as a result, their thrombotic state gets high. And important thing is renal vein thrombosis, which they can present with acute abdomen. Right. So mild edema on feet is generally not seen in nephrotic syndrome. You have gross edema. This will be there in nephritic syndrome. Cholesterol, if you take, it is also now total cholesterol is generally more than 10, because LDL lipase is another hormone which is being passed in urine in nephrotic syndrome. So as a result, cholesterol degradation will be less, and end result will be there will be increased cholesterol levels. So very easy question. I think in pediatrics and all that they always talk about this. Next one they are asking, I think I don't need to tell, but yeah, how do you all remember this? 1972. 2 එකට 0 එකක් දාන්න 19 එකට 0 එකක් දාන්න. So clotting factors will be 10 no, sorry 1 එකට 0 එකක් දාන්න. So 10 9 7 and 2. That is the way you remember vitamin K dependent clotting factors. Very simple question, nothing no rocket science in that. And nowadays this obstructive sleep apnea is another upcoming this thing, and when we were students and all that, they never asked about obstructive sleep apnea because it was not a very not a very important thing to even discuss about. But now change, because with this obesity epidemic, you see a lot of obstructive sleep apneas diagnosed, and there are also new studies. They show that obstructive sleep apnea is directly linked to atrial fibrillation, ischemic heart disease, diabetic, stroke, and all that. So because of that, it is quite important now. So if you see the best now they are asking a best investigation. So obviously the best investigation is a polysomnography. So what you do is you see the apneic hypoapneic index, and based on that you can categorize it. So there is also a screening tool, you call that the stop bank screening tool. Stop bank screening tool can be used for screening purposes of obstructive sleep apnea. And once you diagnose obstructive sleep apnea, treatment will be uh, CPAP in the night, and also weight reduction and lifestyle modification. And of course, there's a certain population of patients with obesity. They have these laryngeal changes in their larynx and all that. So if no causes are found, yeah, there are surgeries in the larynx and all that to treat obstructive sleep apnea. What happens is suddenly they are during sleep, they don't feel it, but their circulation, their respiratory system upper airway collapses, and especially the people who have thick necks and all that, they can have it. So what happens is then they suddenly stop breathing, and when they stop breathing, their saturation goes down, their oxygenation goes down, and they have less oxygen. So as a result, what happens is they become tired, extremely fatigued in the daytime, because they feel extremely tired, fatigue, and they have increased sleepiness is there. They can't even drive. Some people, they tend to sleep a lot. So that is obstructive sleep apnea. Right. So chest x-rays and all that are not done. No use. ABG you can do because if you're suspecting a respiratory failure, where they can go into respiratory failure, they can go into heart failure, they can go into pulmonary edema, pulmonary hypertension. So those are complications of obstructive sleep apnea. And what will happen to the hemoglobin? Hemoglobin levels will be high in obstructive sleep apnea. So then abnormalities in hypothyroidism, again a pretty easy question. Sinus bradycardia in hypo, macrocytosis seen in hypothyroidism, hypercalcemia. Anybody? I think I told one day. නිකම් point out කරන්න නැතුව පුළුවන්ද කියන්න? volunteer කරලා.
True, sir.
Oh yeah. So what happens in hypothyroidism? So in hypothyroidism, it kind of stimulate the osteoclast. What happens when the osteoclasts are stimulated? The bone density gets low. So bone demineralization happens, and bones calcium ticket goes into the circulation. As a result, the calcium levels go up. Hypothyroidism and hyperthyroidism, generally hyperthyroidism is seen in hypothyroidism. Of course, there are case reports against hypothyroidism and hyperthyroidism, but I think in MCQ purposes, it can be false. Elevated CPK is true in both the circumstances. It can be low because it can cause myositis even in hypothyroidism. So myositis can cause increased CPK, and proximal myopathies are caused in hypothyroidism, which also can cause increased CPK. Right. Any questions up to that? Yeah, right. Okay. So next one, features more favor of SLE. Now, this one up in change binary. What do you think? Binary sleeping.
No, sir. Butterfly rash, true, right?
Yes.
Then other one also true.
Okay.
False, true, true.
False. You are the mutilated polyarthritis. Yes, it can happen in SLD, but it is more favor of rheumatoid arthritis. And Raynaud's phenomenon is also, you said it's true, killer.
Yes, sir.
Yes. Yeah, you're correct because Raynaud's phenomenon. But remember this, දෙකෙන්ම එන්න පුළුවන්. Rheumatoid arthritis with Raynaud's එන්න පුළුවන්. Definitely. But Raynaud's is more prone to get Raynaud's phenomenon in SLE than in rheumatoid arthritis. Oral ulcers, double strand DNA antibodies, SLE, and I think we have discussed quite a lot of regarding SLE. There's nothing big. මම මේ chart එකක් දාලා තිනවා. I think changes ටික, I mean, especially the deformities wise. ඒ ටික ඔය චුට්ටක් you have to know because they tend to ask SLE කැමති section එකක් අහන්න ඉන්න more or less in any MCQ. Right. So then next one is the crate bite. Crate causes AKI. Does it cause AKI, Pradeepa? Pradeepa Gihani. Nidhi. Muru, what's up? Does it cause AKI?
No, sir.
No, it doesn't cause AKI. So does it cause a severe local reaction?
No.
Generally, no, because it's a silent killer. No one even knows. What about coagulopathy?
No.
Very good. And what about commonly found in the coastal area?
False.
False, because coastal area it's in the dry area. This may common trait, and especially these farmers and all that were Gambal, Anuradhapura, Polonnaruwa, that area, people who specially sleep on the floor, they are more prone to get crate bite, and these bites especially occur in the night time, not in the daytime. And mind you, there will be no fang marks. Classical scenario කියනද මෙයා උදේ බිම නිදා ගන්නවා ගොවියා මේ කුඹුරක වැඩ ළඟ තියෙන ගෙයක they don't have proper doors and all that. They are very innocent people. And බිම නිදා ගන්නවා උදේ ඇහැරෙනවා උදේ ඇහැරිච්ච ගමන් කියනවා කකුල් පැරලයිස් වෙලා හරි කකුල් දෙකම පර නැහැ කියලා. So සමහරක් අය හොස්පිටල් එනවා, සමහරක් අය හොස්පිටල් එන්නේ නැහැ. එන්නේ නැති අය කියනවා අවස් වෙනකොට දවල් වෙනකොට හුස්ම ගන්න බෑ කියලා. Why? They go into respiratory failure. Because they have a descending type of flaccid paralysis. And hospital එකට ගෙනාවට පස්සේ බලනවා මොකද්ද වෙලා තියෙන්නේ කියලා. There is no bite mark, no fang signs, no local reaction, nothing. And no what do you call coagulopathies. Some patients, they can have paresthesia, some can have ptosis, blurred vision, so they have a full-blown neurotoxicity. Then nail changes. I think I have discussed everything about this. Half nails, CK develop. It's a known feature. Leukonoichia in thyrotoxicosis. Leukonoichia සාමාන්‍ය එන්නේ ඇයි leukonoichia එක? Leukonoichia is when what you call there are white lines වගේ නිකන් whitish nails වගේ තිබ්බම තමයි එන්නේ. Generally it happens in hypoalbuminemia or in nutritional deficiency. It can occur this leukonoichia business, especially in chronic liver cell disease and all that, but not in thyrotoxicosis. Coilonoichia and with this spoon-shaped fingers, චූටි කාලේ ඉඳන් දන්නේවා. So iron deficiency anemia. Nail pitting in psoriasis. Psoriasis you can get subungual hyperkeratosis, tumbler pitting, and oncholysis. ඊළඟ oncholysis and CLCD. Oncholysis and CLCD generally they don't go together. Oncholysis occurs in conditions like thyroid conditions, oncholysis එන්න පුළුවන්. And psoriasis are the two conditions. Other thing is fungal infections in the nail. It can cause. So other nail manifestations that they can ask in the exam are clubbing causes. You have to know almost all the causes of clubbing. I think we have discussed the respiratory causes. There are cardiology causes, then the gastrointestinal causes, Eisenmenger-Schiai, cyanotic heart diseases, and infective endocarditis, then bronchiectasis, idiopathic pulmonary fibrosis, empyema, lung abscess, and causes like that, and even CLCD, thyrotoxicosis, these things can. And then you get the me lines. Me lines can we have lines there. Me lines is a characteristic thing in arsenic poisoning. Then yellow nail syndrome මෙච්චර ඕනේ. Yeah, ඔය ටික දැනගත්තාම ඇති ඒකට nails යන එක. So early warning sign of dengue fever. So this dengue, they asked, I think last time I extensively talked about dengue. So early warning signs of dengue fever. Platelet less than 60,000. So when platelets are low, it implies that patient is going into severe state. But is it an early warning sign of dengue fever? It is generally not an early warning sign of dengue fever. Platelet are less than 100,000 unam, you have to be vigilant. Can this be leaking? But we have had patients platelet count going to 50,000 and no leaking. So it's not an early warning sign. Pleural effusion, yes, it is a known fact, known. That's why the house officers, even you all will be doing ward rounds. In the ward rounds, you all look for pleural effusion, specifically right side of pleural effusion. And if you all are having effusions, it is an indication that patient has gone into dengue fever, dengue hemorrhagic fever. But question is whether it's an early warning sign. Actually, it is. Now, dengue hemorrhagic fever is not the bad thing. Bad thing is the shock. So, you diagnose dengue hemorrhagic fever. By that, you prevent from going into shock. PCV rising. It's a very important thing. It implies patient is losing intravascular compartment fluid that can be either due to dehydration or fluid leakage. Non-remitting abdominal pain. Generally, abdominal pain is an indication of pre-shock. Abdominal pain, vomiting, and all that. But thing here is abdominal pain per se cannot be taken as a sign, but you have to take it as a whole. But anyway, in the context of the MCQ, will take it as true. Temperature has nothing to do with severity or the early warning system in dengue, because generally what happens is after 3 days, the fever spike comes down. So patient will have no fever for 48 hours, and that time the platelets will be dropping. After 48 hours of no fever, then patient will start getting fever again. Right. Then make questions na kiyanne ඕනේ කවුරු හරි. SBS. Next one, first taker. Sulakkana, what do you think? Sulakkana නිදාගෙන ඉන්නේ. So never mind. So I'll discuss this නැත්තම් කියන්න වෙලා යනවා. So now this is a classical important one. So here the hematuria is developing after 1 to 2 days of respiratory infection. So it's a classical IgA nephropathy, which is the commonest nephropathy, commonest nephropathy present. And generally post-streptococcal glomerulitis, they will have 2 to 3 weeks break of fever and all that. Then only after the break only they will get. But IgA nephropathy, sore throat again, IgA nephropathy. You can get recurrent microscopic hematuria, intermittent macroscopic hematuria, or patients can be asymptomatic even. Next question, Nika. So there are all the features, and as increase ACTH levels and other features are there. Cortisol suppress කරලා තියෙනවා. So cortisol suppress කරලා ACTH levels are high කියන්නේ, that means there should be primary adrenal insufficiency. If it was secondary adrenal insufficiency, the ACTH levels will be normal. In SIADH and all that, this inappropriate secretion, patients will have. A patient will not have this, will have hyponatremia, but there will be no hyperkalemia, and cortisol levels will not be low in ADH, in SIADH. SIADH is quite common in medical wards as well. Hypothyroidism, yes, it can cause hyponatremia, but hyperkalemia is not seen. Con syndrome, you see hyperkalemia, Con syndrome, you can see, and they are generally Con syndrome, they will have hypertension. Here, it's hypotension, and they can have postural drops and all that in Con syndrome, in Addison's disease. Right. This one, this is an interesting question. Muru, what do you think?
Actually, I couldn't done the paper before, so
Never mind. So we'll go through it. So if you read the question, you can see that now this patient, now see the clues. This is a tough question. Patient is a woman, 30-year-old, young ekkene. And yes, Muru? Yeah. So patient is a young patient. And patient then මොකද්ද කියන්නේ no symptoms, feels well, and Graves disease history එකක් තියෙනවා. දැන් එනවා ඔය ඉතල thyroid function එකක් අරන් එනවා TSH එක 0.01, but free T4 ඒවා ටික normal. Sorry, free T4 is high. 48, free T3 is also in the marginal state. So දැන් මේ thyroxine දැන් මෙයා Graves තියෙන එක්කෙනෙක් routine review එකට එනවා, no current symptoms, clinical euthyroid, no goiter, no tremor. එතකොට එයාගේ labs ටික බැලුවොත් the TSH is suppressed, the T4 is high. So what can this be? Now if I think these type of questions, you have to rule out things. Relapse of Graves disease, let's keep it up. Thyrotoxicosis, thyrotoxicosis due to liver thyroxine injection. Now generally ඒක මේකෙන් කියන්නේ නෑ ඇත්තටම generally, but it's possible if the patient is taking that. Important remember. TSH secreting pituitary adenoma. Now if TSH secreting one, TSH level should be high, it can't be normal. Subclinical hypothyroidism. In subclinical hypothyroidism, patients will have no symptoms, but their TSH will be suppressed and their T4 will be high again. So it is a possibility. Subacute thyroiditis, generally they will have fever, they will have symptoms and all that. Subclinical thyroiditis, subacute thyroiditis, or deep coherence thyroiditis and all these things. So now this patient, there is no symptoms. So no symptoms, she's completely fine. So since there is no symptoms with elevated T4 level and no TSH, you can label this as subclinical hypothyroidism. Yeah, next question also. Yeah, මේක කියන්නේ මේ classical farmer කෙනෙක් එනවා with all the diarrhea, dumbbells ටික මම දන්නේ. Diarrhea, urination, meiosis, bradycardia, bronchospasms, lacrimation, saliva, and sweating. So this is a classical organophosphate poisoning. Now, organophosphate poisoning also they can ask in the exam actually. It is important. Now, how do you manage the patient? So what happens is when the patient comes, you have to remove the contaminator. That's the first thing. Because if you don't remove it, wash the exposed skin with soap and water. Irrigate the eyes if eyes are exposed. And if patient has orally taken it, you can do a gastric lavage if coming within 2 hours. If unconscious GCS is less than 7, you have to intubate. And you have to give activated charcoal if coming within 4 hours. You can give via NG tube. So then you have to look for cholingeric syndrome, bronchospasm, sweating, meiosis, and all these things. And if these symptoms are there, you have to drug of choice will be IV atropine. You atropine, how you give is now you start with 2 milligrams and you double the dose of atropine every 5 minutes, and until the endpoint will be clear lungs, heart rate more than 80, blood pressure more than systolic blood pressure more than 80, dry axilla, as well as give me a second. So these are the endpoints. You have to remember these endpoints because these are frequent MCQ questions. It's the endpoints. And then once the endpoints are reached, you have to calculate the total amount of atrophy. We'll imagine that they have given 100 but 100 milligrams of atropine, then you have to take 20%, and 20% ගන්න එක 20 milligrams අරගෙන ඒක මේ infusion එකක් හැට you have to give the rest. So you have to check when atropine is going on, when there is features of polygenic symptoms, these should be monitored, and also atropine toxicity should be monitored as well. Other antidote is pralidoxime. Pralidoxime, there is a place if they are present within 24 hours, and especially there is a thing called intermediate syndrome, which there is paralysis after organophosphate poisoning, then pralidoxime will be the drug of choice. So next question, I think you all know there's nothing big to talk about this. This is a classical pancostal tumor. So pancostal tumors are also frequently, you can see pancostal tumors. What happens is there can be a tumor in the apex of the lung, and which can cause this nerve plexus injury, and they can even call this phrenic nerve injuries, they can cause sympathetic trunk injuries, and all these things. So what, as a result of all these things, they can get a C8, T1, T2 dermatomal sensory loss, shoulder pain and arm pain will be there. Because the sympathetic trunk gets damaged, they can have a Horner syndrome. And when the C8, T1 dermatomes are damaged, the nerve roots are damaged, they can have small hand wasting, atrophies of the small muscles of the hand. And apart from that, they can have their normal other lung cancer symptoms. Right, so that is paper 1. Is there any questions? Yeah, no one is asking questions, so that means everything is well understood. So I'm moving on to question paper 2. 2 එකත් මම explain කරලා තියෙනවා. Hepatitis A does not cause CLCD. What causes CLCD is hepatitis B and hepatitis C. Anorexia is seen in hepatitis B, but hepatitis A, but we can't say it is characteristic. There are other things going on as well in hepatitis A. I have put this normal මගේ අර කලින් class එකේ අපි කරපු note එක දැම්මේ. So I mean almost everything will be here in this note. And so their symptoms will be quite non-specific. So in a patient who's having non-specific symptoms, you can't say anorexia is characteristics. Absence of jaundice exclude the diagnosis. Actually, it's false, because their clinical stage, some patients can remain anicteric. That means they can be having no jaundice right through the infection. And then aplastic anemia is actually seen in hepatitis B. Antiviral treatment of choice, generally their treatment will be conservative, like symptomatic treatment. Of course, you can give the vaccine if they are traveling to India and all that, but generally symptomatic management is what we practice. Then they do not care. Other important thing is they do not cause liver cancer. and their incubation period is for 2 to 3 weeks. So if you take regarding SITs, shifting dullness එක question එක දීලා නෑ මොකුත් නේ. Shifting dullness is suggestive of we'll take it as I don't know, keep that right. So high doses, high aldosterone is recognized. So SITs, if you look at the pathogenesis of SITs in CLCD, what happens is now there is fibrosis of the liver, and as a result, there will be intrahepatic sinusoidal pressure goes up. As a result, the portal pressure goes up. So due to this portal pressure going up, there will be backward pressure, and as a result, the splanchnic system will be vasodilated. And also further, this nitric oxide, VGF, and all this, they are responsible for this vasodilatation. So what happens now as a result of this vasodilatation, the splanchnic circulation, the effective blood එකේ ඒ කියන්නේ ඔක්කොම අර liver එක නිකන් fibrous වෙලා ඔක්කොම dilate වෙලා තිබ්බම අර nitric oxide උයේ ඔය secrete වෙලා මේ splanchnic circulation එක dilate කරනවා. මේක dilate කරාම වෙන්නේ ඇඟේ අනිත් තැන් වල තියෙන blood will go and stay inside the liver, and then circulating volume will be low. As a result, there will be renin angiotensin system be activated, and as a result, it will cause increased sodium reabsorption, and it can contribute into SITs. So as you can see here, and apart from that, these hypoalbuminemias and all that, they also contribute. So as you can see, the renin angiotensin aldosterone system is activated here. So it is an important component here as well. So if you so if the polymorphs are more than 250, it's bacterial peritonitis, spontaneous bacterial peritonitis. Protein level is high in tubular ascites. Yes, the acidic fluid protein levels will be quite high. And a common question is the portal hypertension. The SAG, the serum albuminic acidic gradient, generally will be more than 1.1, especially in CLCD, when it will be less than 1.1 in tuberculosis, in carcinomatous peritonitis, in nephrotic syndromes and all that. So ඊළඟ එකත් මම හිතන්නේ I have repeatedly talked about this section about this what do you call antispon. So buttock pain can be a presenting feature. Actually, it's a well-known feature. Yeah. Because one thing is the buttock pain will be alternating buttock pain, and they can have inflammatory type of abdominal pain. Inflammatory type කියන්නේ කෑග ගහ ඉන්නවා ගෙදරටලා ඉන්නකොට ඇවිදින්න ගත්තට පස්සේ pain එක නැහැ. Reduce with activities, and also they will complain of they will have a lordosis, forward flexion of the spine. Sober's test කියලා කරන්නේ ඒවමයි ඉන්න තමයි. And sacroiliitis තියෙනවා. Atlantoaxial subluxation, neck problems එන්න පුළුවන්. They can have peripheral arthritis and all that as well. So difficulty in bending, I just now said, because they have this bamboo shoot spine and all that. අපි Sober's test කියලා බලන්නෙත් ඒක කොච්චර bend වෙන්න පුළුවන්ද කියලා. So it will be difficult in bending. Scleritis, generally more than scleritis, what they have is uveitis. Scleritis is seen in rheumatoid arthritis. Anti-uveitis තමයි common actually. Rapid response to methotrexate, we can't tell that this drug rapidly responds to methotrexate, because methotrexate is not a well-known management strategy. It's used, but its biologics are also used, but it doesn't have a rapid response. History of ulcerative colitis, you should entertain that as well, because why? Anti-AS, there are 10 A's in this, so you have to remember all 10 A's: the atlantoaxial subluxation, anti-uveitis, apical fibrosis, aortitis, AR, AV block, amyloidosis, IgA nephropathy, and cord equina syndromes. So regarding acromegaly, I think it's very easy. There is increased intradental separation. Osteoporosis, yes, it is seen. Moon-shaped faces are seen in generally in cortisol excess secretion, like in Cushing syndrome or steroid usage. They have spade-like fingers and prognathism. I'll tell you, if you want to study acromegaly, best thing is to, there is a wrestler called Great Kali. What a Great Kali photo එකක් ගහලා බලන්න, you can cover up the whole features of acromegaly. You can remember almost everything about this. Prognathism කියන්නේ යටියන්ද ඉස්සරහට ඇවිල්ලා තියෙනවා කියන එක. Yeah. So hypoglycemic drugs, you have to know almost everything about hypoglycemic drugs. Glibenclamide is not the drug of choice in elderly. It is in fact contraindicated in elderly because it causes malignant hypoglycemic episodes. Then it is not even used anymore. Nowadays, I don't think you can even find it in a pharmacy. Insulin and oral hypoglycemia should not be combined together. It's false. It's being combined. Metformin reduces appetite. Yes, it's true. They give a lot of dyspeptic symptoms. Sulfonylurea causes weight gain. Actually, it is true. Insulin and sulfonylurea can cause weight gain. Actually, it happens because sulfonylurea increases the insulin release. It kind of increases the insulin amount in the body. As a result, they will have weight gain as well. Metformin, there is a percentage, about 10 to 20% of the patients will have some set of weight loss as well in metformin. I think this next question I have discussed last week, so I'm not going through it. So statins causes myalgia, contraindicated in pregnancy, true. Induce it inhibits HMGA co-reductase. It's both primary and secondary prevention of myocardial infarction. It's obviously better than fenofibrate. Last time I think I explained about other anti lipid drugs which can be asked in the exam. This question also, I think, did we do it last time? Megha, yeah, I think we did it. I mean, the most possible one, I think all of you all agreed with it, was subdural hemorrhage. Ne? So strongly suggestive things of Addison's is hyperkalemia is a very important thing. Hypernatremia, hyponatremia, slightly positive Mann test is seen, but it is not a feature suggestive of Addison's disease. Because sometimes TB you can get Addison's disease. Hypertension, of course, Addison's no, you get hypotension, postural hypotension. They can have hypermagnesemia in Addison's. There are other causes of hypermagnesemia as well. You have to remember, especially these antacid, and when you obviously treat with magnesium sulfate, diabetic ketoacidosis, rhabdomyolysis, then by increasing the renal magnesium absorption in hyperparathyroidism, in familial hypocalciuric hypocalcemia, and of course Addison's disease. So hyperkalemia is seen in Conn syndrome. Now make a MCQ the Conns obviously. Addison's no, severe vomiting, it's hypokalemia. Rhabdomyolysis, you can have hyperkalemia. Digoxin therapy is quite weird, right? When digoxin, they ask quite now digoxin is a very weird drug. Digoxin, what the action is, they go and inhibit the sodium potassium pump. So as a result, what they want to do is මේ sodium pump එකකින් වෙන්නේ potassium ඇතුළට අරගෙන sodium එළියට දානවා. So this guy wants to keep this sodium in the body, inside the cell. So as a result, what happens when sodium is inside the cell, මේ sodium එකත් එක්ක exchange කරන්න පුළුවන් calcium ටික. So the calcium amount will be more in the myocyte, and as a result, the contractility will be high. So digoxin, two indications are given. One thing is in atrial fibrillation, other one is in heart failure. But heart failure, it has no mortality benefit, only a rate control level. Two important things is when there is hypokalemia and hypomagnesemia, you have to be very cautious in giving digoxin because it increases the chance of digoxin toxicity. And their side effects is also important. I think you all know the ECG findings. They are the tick sign, reverse tick sign. Their side effects are there. You can have blurring of vision, photophobia, visual disturbances, visual hallucinations, and obviously the GI signs. Then the cardiac side effects are you can have bradycardias, and then of course there is gynecomastia. Yeah, so recognized features of adult polycystic, uncontrolled blood pressure is seen.
Also,
Yes.
hyperkalemia cons is false, right? False.
Hyperkalemia cons is false. නේද? Yeah. Hyperkalemia cons is false. මම true කියලාද කිව්වේ ඒක?
I think so. Oh.
Yeah, it's false. Actually, cons, it's the opposite of additions, right? Yeah. And rhabdomyolysis, of course, rhabdomyolysis generally happens. There's all these muscles, myocytes start breaking down, and as a result, they will have bad AKIs. So with even the muscle breakdowns, the potassium will be released. The CPKs will be 10, 20,000 and all that. They will have severe muscle pains. So very difficult condition to manage. Hemodialysis will be the treatment. They will have brown color, like reddish brownish urine being passed, and those will be the symptoms. Right. I want to tell something else. Other thing they ask is hyperkalemia and hypokalemia and hypertension causes. So from here also you can tell Conn syndrome is one. Renal artery stenosis oil also have hyperkalemia and hypertension. Any other cause?
Renal failure.
Renal
Sick.
failure. Yes, renal failure can also have hypertension and hyperkalemia. So those causes, the other thing is when a well-known patient who is having hypertension is on diuretics. These things they can ask. They are very hotspot questions in the exam. Right. So polycystic kidney disease, uncontrolled blood pressure. Yes, they can have very high blood pressures. And blood pressure, there is this theory that this is the renin-angiotensin mediated one. Do you think that when there's this polycystic kidneys, this cyst, the nephrons increase and they kind of produce renin-angiotensin more, renin more. So as a result, the whole system gets activated and blood pressure goes up. So their treatment of choice will obviously be ACE inhibitors. And these LVH also, their blood pressure, they will have bad LVHs in the heart as well. Then subarachnoid hemorrhages, yes, there is a percentage, 10%. I think you have to remember this percentage. 10% of patients with polycystic adult autosomal dominant polycystic kidney disease, they will have SAH. But just because 10% has SAH, you don't screen for subarachnoid these berry aneurysms and all that. But if they have a family history of sudden death, if they're having headaches, and if they are having a family history of aneurysms, then of course these patients should be screened. Painless hematuria, generally their hematuria is quite painful because when they can get hematuria with a ruptured cyst, which can be painful, and also they are more prone to get calculi, which can also cause painless hematuria. This is generally, I don't know this question, they have autosomal recessive polycystic kidney disease as well, but this is not that type we are talking about. Recurrent UTIs is quite common, more than recurrent UTIs, but the important thing is they can have these cyst infections. It's very difficult to treat those, and because they don't penetrate, the antibiotics don't penetrate the cyst, and they can have cyst ruptures. Other thing is they can have cyst in the liver, the pancreas, and some are associated with the mitral valve prolapse, and also they can have polycythemia as well.
So painless hematuria we take as true, right?
Painless hematuria, it's a very, very, very tricky one. This painless hematuria thing, because generally hematuria occurs. I have seen patients with painless hematuria, but by theory, hematuria occurs either due to a calculi or due to the cyst rupture. So both instances, they cause pain, both of them. So what they're asking here is recognized features. It should be painless hematuria, should be false.
So isn't the classic presentation painless hematuria in a young patient rather than a painful one?
Classic hematuria is generally you can get renal failures. You can generally it's not painless hematuria per se, but as you said, I have seen patients with painless hematuria, but it is not in the what do you call painless hematuria. Just don't occur without the cyst being ruptured.
Okay.
Good question. Right. And other thing is about screening. They can ask about screening as well. Ultrasound, they use ultrasound scan for screening purposes, especially depending on the age. If they are less than 40 years old, they don't have to have a lot of cysts. One cyst is enough. More than 40 years, they have to have two or more cysts in two kidneys. So there's a criteria to diagnose, to screen for autosomal dominant polycystic kidney disease. So SBS, I think very easy. The next one, nothing to even talk about. This is a rapidly progressive glomerulonephritis. This is a very unfortunate condition. Rapidly progressive. Generally, we see in these good pasture syndromes, this glomerular basement anti-GBM antibody nephritis. So once they develop crescentic, you can't even diagnose what is the cause. You have to just aggressively treat, dialyze, and see whether, and even start with cyclophosphamide and all that. Or other two treatments, IV cyclophosphamide pulses, and even IV methylprednisolone is used because this patient is having a rapidly proliferative glomerulonephritis. This is an interesting one. What did you all think? Give me a second. Yeah, I think yeah, this now got a call from saying that there is a patient in the ETU. Troponin is positive, no chest pain, coming with atrial fibrillation. Is it possible? No answer. Okay, it is possible because atrial fibrillation can also cause increased troponins. Okay. May answer for 2 and 4 කියලා අහලා තියෙනවා. 2 and 4 කියන්නේ 2 and 4 මොනවද MC can you what 2 and 4 questions the didn't get your this thing. Right. So next one is an interesting question. Now okay, can someone just did anybody get a possible answer at least for these? These are the type of tough questions. These are the important questions. These
Right.
anybody? Yeah.
It's B.
You're thinking it's B. So you want ANA to be positive, anti-double strand DL to be negative.
Like
low-
ideally, I would want it to be positive and low C3, C4,
Yes.
but it doesn't have an answer like that.
It doesn't have. So ideally now they are asking active SLE නේ. Active SLE නම් they were තුනයි වෙන්න පුළුවන්. One what? Their ESR will be high. Their anti-double strand DNA will be high. Their C3, C4 will be low. So ඒ තුනම තියෙන උත්තරය නැහැ. So answer is no answer here. But I think for the sake of the argument, I think B is correct here. But I don't think make a exam එකට දෙයි කියලා. This is not a good question actually. I mean a question, but theory, it's a learning. I mean the theory point is there, no? So you got the theory point, no? So these are active SLEs. I mean generally active SLE කියලා කියන්නේ කොහොමද? එකකින් විතරක් යන්නේ නැහැ. Not the investigation. You have to take the clinical history. You have to take the clinical investigations and examination. Now, this patient, if they see the history, rash එක තියෙනවා, joint pain, so there is an active SLE in this patient. Now, you need to confirm with the test. Generally, for disease activity is not related to ANA. ANA will be positive. But the double strand DNA is the utmost important, and low complements and high ESR, it is important. Just remember that for your exam. Next one also, I think next one කියවලා අපරාධයක් කියව කියලා හිතනවා නේ. Anybody? Ali Ahmad. Ali Ahmad ne? Shamatka De Silva.
B.
B නේ මේක B ද කිව්ව D ද?
B, sir.
B. B for bat.
Yeah.
Yeah. So patient has yeah, it's a hepatitis A infection. Classical, but the ALT is more than AST. This is the initial part, and he had gone somewhere to endemic area, most likely India. So thing is about this acute hepatitis A, it's okay, so, but sometimes these patients can go into fulminant hepatic failure. That is the problem when they develop fulminant. So then, and when these patients come, you don't know what it is. So you have to do all these hepatitis antibodies to come into a conclusion. Next question, I think I have described it also. Now, this is ST elevated myocardial infarction. Ideal treatment will be obviously to go for this thing, not what to go for a primary PCI, but if as I told earlier, if primary PCI cannot be done within 160 minutes, you have to go with a thrombolytic therapy immediately and transfer. So, do you need to do a troponin in this patient?
No, sir.
Yeah, no, but very good. So you all know the answer. Means අපි වෙලාවට call එනවා troponin කරනකම් ඉන්න ඕනේද කියලා අහන්න මේ ST elevation ආව. So you don't chest pain and this thing, obviously you have to go and thrombolyze. Now I'll give you another point in this patient. The blood pressure is low. So blood pressure low කියන්නේ most likely this patient may right ventricular infarction එකකුත් තියෙනවා. So right ventricular infarction. So these patients, you need to give a lot of fluids, and you can give up to 1 to 1.5 liters fluid. Sorry, because of the RV infarction. Yeah. Next question. Clear cut. මේකත් medical wards වල very common scenario. දැන් ඔය heroin addicts ලා ඉන්නවා හරියට. They overdose themselves and they come. You don't have any history. Only thing, every patient who comes with unconsciousness, torch check ගහලා pupils බලන්න ඕනේ. So if the pupils are pinpoint pupils, there are two differences. One thing we have to think about pontine infarctions or pontine hemorrhages. You do a CT for that. Other thing is heroin overdose or opioid overdose. So then for that, what you have to do is you have to give IV naloxone, and this patient should be intubated as well. So if there is a benzodiazepine overdose, flumazenil, then no problem is you can get fits, but it is the mode of treatment here, right? So you don't give charcoal and all that in these patients. Naloxone තමයි දෙන්න. So
benzodiazepines, should we take flumazenil as answer or supportive as answer? In a question, if there were two options, give flumazenil or supportive.
If you're sure it's benzodiazepine poisoning.
Hmm.
Any question?
Yes, sir, because some guidelines don't recommend giving flumazenil because of seizure risk. In Sri Lanka,
Yeah, sorry, my battery this thing went. So I was saying you have to take flumanacil as the answer because this benzodiazepine business is also quite common. It's seen in a lot of casualties, and you have to kind of know your suspicion is very important because if you are not suspecting, uh, you're not going to kind of diagnose at all. I can remember one patient I coming E2 එකේ කෙලවරක දාලා තිබ්බ patient කෙනෙක් and there was no diagnosis. Patient was unconscious, some big shot CEO, and I had no clue in middle of the night. ඊට පස්සේ phone records එහෙම ඔක්කොම කරලා බලනකොට pharmacy එයාගේ call එකක් record වෙලා තියෙනවා. pharmacy එකෙන් අහනවා මේ alprazolam ගත්තම මැරෙන්න පුළුවන්ද කියලා. So immediately when I heard that, I gave flumazenil 600 mics, and patient woke up in about within 1 hour woke up. Yeah. So it can change with the diagnosis. Quite common. So with that, any other questions? I may just for a now. I assume our our class there are, I mean, the guys who are, there's a set of guys who are listening as well, through what do you call the video, going through the video instead of the live class. Maybe it's easy for them as well because ටට්ටක් ගාලා බලන්න පුළුවන් නිසා. So there are old syllabus and new syllabus as well. And I think I assume you all know, do you all know about the marking the what do you call the stems and all that, marking schemes and all that? I think all syllabus, of course, there is no question about it. All syllabus, of course, pretty easy. That just 25 SBAs, you have to at least try to get 13 correct, and 125 MCQs, and at least 90 or at least 60 MCQ stems should be correct. I mean, my advice is it doesn't matter what syllabus it is, right? The new syllabus now, they have 50 SBAs, and at least you have to mark 25 when you combine pediatrics and medicine. At least 25 should be marked for a pass. And MCQs, of course, there are 250 stems, and at least 125 should be marked. So, and good thing is now it doesn't matter, you can't leave one, the new syllabus guys can't leave, you can't say that pediatric is not needed or medicine is not needed, both are needed. And no matter what this thing, you have to uh, my strong advice the first day I told you all was, don't be overconfident. You have to be confident but not overconfident, and don't try to mark all the stems. That is how you tend to get low marks. Now there are some people in MCQs, they are extremely good. Now, I mean, my class, I mean, this MCQ class, I have been discussing this with Sudhir also, that I have identified two or three guys who are exceptionally good. They will definitely be first. I mean, definitely they can. I'm 100% sure they can. They are much better than most of the medical students I have seen, and superb knowledge, and they are definitely going to be first. And even if they do the common MCQ in the local one, they would come first 10. That much sure. So those guys, they are good, but try to mark what you know, because MCQ is tricky. It can, if something is going to give you a negative mark, better not mark it. Especially if you can put 4, if you can mark 3 is enough. don't try to go with 4 if you're not sure. If you're sure, just go 5 even, no problem. But don't be overconfident and have less marks, because those the few I told, they are 100% sure that they will pass with a 100% sure that they will pass, but they have to pass with a good mark because their standard is good. Others also, I mean, most of the people who I can't comment about the guys who didn't interact, but the guys who interacted are extremely good. So y'all can definitely pass, but you need your motivation. Don't be overconfident, but just have that belief that you are going to pass this exam, because that is the fundamental primary thing which is important. Because and when the exam comes close, you tend to be stressed out and you can't even think what you're going to do. So when if you have your motivation, if you have your go, it will be a bit easy for you. So all are good, all can pass this exam. Now, the good thing about it, I was talking with a person who is involved as an examiner for the exam, and he was saying that they are trying to get more to the system, because now many are migrating, right? There are a lot of vacancies to be filled in the government sector, and huge deficit of doctors and even specialists. So they are trying to get hold as maximum as possible. Those days ERPM was an exam just to get the limited amount of number, but now they are open to get as much as possible who pass the exam. So this is the best opportunity for you all. You don't have to stay here, but just pass this exam and kind of do it. So again, I'm reminding. Uh, if you all are having any doubts, I think daily basis now I'm getting questions, so y'all can just personally WhatsApp me. If I'm not in a case or anything, I will try to reply all. So you all study well and do like that. So I think our these limited classes are over. Is Sudhir there?
Yes, sir.
Machang, yeah. So I think no, I was telling about the exam structure and all that.
Okay, sir.
So may I think our limited this thing is over, so we can. I mean, if there's anything else, they can personally ask questions and somehow manage this exam. No,
Yeah.
anything you want to add, Sudhir?
Not really, sir. I think most of them they know how to mark the exams. So little things like so for those who are doing the new syllabus, obviously now the mathematically now you have to mark somewhere around 160 stems to 180 stems, and unless you are very brainy and you have studied the entire the syllabus, you better not to mark beyond 180 stems. So that might carries a risk of you getting lower marks. But if you're some average student, I think best thing is to mark somewhere between 160 to 180 stems in MCQ, all three papers. Regardless of the paper 1, 2, or 3, all three papers, the sweet spot would be around 160 and 180. And below that and beyond that also carries a risk of getting low marks. And the other thing that just keep it in mind that you all have to get 50 marks to pass the exam, whereas the all syllabus you only need 45. So just keep that in mind. You all need to like I think the new syllabus people they all have like 10 more days at least, and the all syllabus you have somewhere close to 3 or 4 days. So what needs to do is in these few days revision. I mean, revise all the things and go through what you have done mistakenly, and then read around it. I mean, there is no time to watch classes. I mean, unless you are very poor in that particular area, better to, revise by questions. So that's it, sir. If there's anything, I think you can message sir, and we will try to, help you at our earliest convenience. So, yeah, so that's it.
Yeah, no. So that's it, and so then hopefully, let's hope that you all will message us saying that you all pass, ne?
Yeah, sir. Fingers
Yeah,
crossed.
fingers crossed. So positive vibes and good luck for your exam. Any question, please ask. Huh? Okay then. See you, Sudhir. Then, na. Thanks for organizing this class. I think a lot of guys benefited it.
Yeah, no
So
worry. All right.
Okay, see you. Good night. Bye.
Yes, good night. Bye.